Thank you so much. I would like to thank AIOS and Dr. Shomshila ma'am for giving me the opportunity to talk about management of corneal perforations in COVID times, our experience. I don't have any financial disclosures. So we all know that COVID has changed the world. It is we recently saw the another dark side of the COVID during second wave in the form of post-COVID mucormycosis. And along with COVID, there have been multiple phases of lockdown, and because of lockdown, so many other medical services have been affected, including corneal tissue availability and corneal transplantation. So there are multiple articles published during these times which shows that the corneal transplantation has been vastly affected all over the world. There was also fear of having transmission of COVID by harvesting cornea from the donor who has acquired COVID, and so it is recommended in this to do RT-PCR test from the nasopharyngeal swab of the donors and also from the blood. The another data from the American Eye Bank Association from the March 2020 that the volume of tissue distribution has drastically come down to 7% at the domestic level in US and internationally to 6%, which even went further down to only 4% and 1%. And just within a matter of weeks, the ophthalmic care came down to halt in United States and all over the world, including elective corneal transplantation. So corneal perforation is one of the two ophthalmic emergencies. It has a varied presentation, and most of the corneal perforations have etiology in the form of infective keratitis. And you can see that in certain larger perforations, you need actually urgent therapeutic penetrating keratoplasty to save those eyes. But during COVID times, it has become a huge challenge for every cornea surgeon to manage such eyes because of unavailability of the corneal tissues. So these are the protocol which we followed during COVID times in Sitapur. So for all the routine impending perforations or small perforations, tissue adhesives with cyanoacrylate glue and BCL was the procedure of choice for most of the cases. The dilemma was when the perforation was little larger, more than 2 millimeter, but less than 5 millimeter. So if we didn't have any option, we have went ahead with the tissue adhesives on such cases also, and we have got good results for that. Another technique which is unconventional, which we have applied, I've learned from my senior, is tissue adhesive followed by a layer of a plastic drape, which is very thin, followed by another layer of tissue adhesive, and over that BCL. I'll be showing a video of that. Tina's face graph, Dr. Purvasha has covered very nicely, so I'll not go into detail of that. And I will show a case of conjunctival pudding flap, which I have performed for a case where perforation was in the periphery. For larger perforations, it is important, if possible, to do a very gentle B-scan by an expert to rule out vitreous exudates. And if you see any evidence of endophthalmitis, in such cases, it will be advisable to go for evisceration. But if patient has a perception of light and there is no evidence of any vitreous exudates in the posterior segment, we have saved few eyes by doing gunders and flap, which is an old surgery, but still in such desperate times, it has been a huge help. So recently there is an article in Indian Journal of Ophthalmology about the use of glycerin preserved corneal tissue in emergency corneal transplantation. So if you have any corneal tissue available, use them judiciously. Try to preserve the corneal scleral rim, so which can be used for a patch graft in an emergency situation where there is another perforation in certain scenarios, and you can preserve the corneal scleral rim in the glycerin. So I'll be showing this one of the case where there is a corneal ulcer with central microperforation, but the anterior chamber is flat. So after anesthetic application of anesthetic and trying the surface, I'm applying the cyanoacrylate glue using 30 gauge needle, covering the perforation and the surrounding tissue slowly, letting it to dry and crystallize. After crystallization, another 30 gauge needle is inserted tangentially carefully to enter in the anterior chamber is completely flat, and the air bubble is inserted. You can see the air bubble reached the opposite end of the limbus, which means the anterior chamber is completely formed and the BCL was applied. So in such cases where the perforation is little large and there is a uveal tissue prolapse, the different approach we applied. So after applying the anesthetic, the surface is dried. The first layer of cyanoacrylate glue, making a hanging drop preparation, is applied. After letting it dry a little bit, another layer of a plastic drape cut in the fashion to cover the defect is applied over it, and it is also allowed to dry. Following which the anterior chamber formation is attempted using a 30 gauge needle, and air bubble is inserted, but you can see the air bubble is not reaching to the opposite end of the limbus because of the uveal tissue incarcerated to the corneal perforation. So after making the side port and inserting a little bit of OVD, the uveal tissue is reposited back into the anterior chamber, and you can see after reposition of the uveal tissue, still the area of perforation is not leaking, and it is withholding the perforation. The drape is still there. Following which the air bubble is complete, and following which there is another layer of cyanoacrylate glue is applied, and over which the BCL is inserted. So this technique is unconventional. It was a desperate measure in desperate time, but it has worked for us, and it has shown a good results in certain cases. But definitely these patients will need a definitive treatment of corneal transplantation at a later date. This particular case I managed with a similar technique where the perforation was approximately 2.5 millimeter in size with the flat anterior chamber. So multi-layer glue over drape over glue is applied, and following this, the anterior chamber is formed with the air bubble, and BCL was applied, and patient's eye was salvaged. This is the case where there was a peripheral limbal tear with the tissue loss, and uveal tissue was prolapsed. So the scleral patch graft was fashioned from the previously preserved corneal scleral rim from a previously done corneal transplantation. You can see the patch graft is well sutured to the cornea and sclera on both the sides, and then conjunctiva is closed over it, and the anterior chamber is very well formed without any leak. This is another case of the corneal perforation with the uveal tissue prolapse having the peripheral perforation on the nasal side. So after reposition of the uveal tissue back into the anterior chamber, I fashioned the conjunctival tenal flap and pulled it over the area of perforation, then sutured it to the cornea using a purse-string kind of a suture, and then patient's perforation was healed, and patient did well following the procedure. In such cases where there is a large perforation with the total corneal melt, where in an ideal scenario you would want a corneal tissue available to do a therapeutic corneal transplantation, but during COVID times we didn't have tissue, so I went with the Gunderson flap, and after end of 1 month, the last picture is at the end of 1 month, the graft is retracted from above and below because of the elasticity of the tissue and contraction of the conjunctiva, but still it is covering the defect, and the eye was salvaged. So it is always better than at least evisceration. And this patient was also managed with a definitive corneal transplantation later date. So this is the case I want to share, which I've been managing since last year's COVID lockdown period and post-lockdown period where tissues were not available. So patient presented to us in June 2020 with the central corneal perforation with surrounding corneal abscess. In an ideal scenario, I would have gone with the therapeutic penetrating keratoplasty right away. But as tissues were not available at that time, I went ahead with the cyanoacrylate glue and BCL application in June. After which, after long follow-up and close follow-up and meticulous medical management, the cornea completely healed with the total corneal scar and vascularization. With the vascularization managed with final diathermy before preparing the cornea for the transplantation. Patient underwent corneal transplantation in October 2020, but this was not the end. Patient again presented with loose sutures and reinfection along with hypopyon. So after resuturing and change of medications, patient's graft survived, and this is the photograph of December, and recently I've seen the patient in May 2021, and patient's graft is still surviving. So with these multiple options available and with the meticulous management, we have been able to salvage many eyes. Important thing is you have to be very patient. I would like to thank Dr. Karan. He has been a great mentor to me. He is my brother and my best friend. He has also helped a lot with this presentation. And thank you so much for kindly listening.